There's another story, Troy, that has made very, very little impact, I think, in the New Zealand media world today. And this is where we're going to start. We won't get too much into the article because we're about to have a guest coming on. Health New Zealand wants to cut 4 chief medical officer roles. So what is this all about? Pardon me. What does this story mean? What is a chief medical officer? We have with us a Northland emergency doctor, Dr. Gary Payinda, joining us. And good evening to you, sir.
Good evening, Pat. Hi, Chewy.
Now I've asked you to come on board because I've seen you've been tweeting about this, so you're across this. But just to let other people know exactly what we're talking about to start with, Health New Zealand wants to cut 4 chief medical officer roles. This is first published, I should say, on RNZ. Health New Zealand wants to reduce the number of chief medical officers from 18 to 14. So that's 4 out of 18. So that's what, 20%? 20% of them, whilst also promising not to cut frontline medical roles. The Senior Doctors Union say this will lead to a reduction in critical clinical leadership roles overseeing safe patient care in hospitals around the country. The proposal is to cut the 4 roles by integrating the small health regions of South Canterbury, Wairarapa, the West Coast and Whanganui into neighbouring larger ones and merging the Lakes and Bay of Plenty regions leadership. The Association of Salaried Medical Specialists, ASMS Union, says some chief medical officers' jobs would grow in size while others would disappear. Thank you for being with us, Gary, to decipher all the Latin that I just read that we don't understand. Can you just explain to us, first of all, what is a chief medical officer, a CMO?
A chief medical officer is typically a very senior and well-respected doctor at the hospital who gets put in a position to supervise all of the medical education of the young doctors in training and the senior doctors to handle patient complaints. So when something goes wrong, they're often a first stop in terms of investigating and disciplining and ensuring quality of the medical services at a hospital. And a chief medical officer, I mean, you could think of them almost as like a general of a platoon or something like that, a leader.
Okay.
And to not have one is, to my mind, wild. I've never worked at a hospital that didn't have a CMO. They're an integral part of clinical leadership. And for any government that talks about clinical leadership, like it's good to have clinicians in leadership roles, like that means the CMO. And to can that position at 4 hospitals it's very inconsistent with the message of encouraging clinical leadership. It's sort of the opposite of what you'd want to do.
So it sounds like you're saying it's essential to have one per hospital. Like if they brought 2 hospitals together under one branch, maybe an hour apart, but in a similar region, and there was only one in one hospital, that sounds like that's what they're talking about, integrating the small health regions. That would be not as effective. They couldn't operate that way.
Well, every staff has its own unique challenges, right? Every mix of doctors, every patient population, every community will have limitations and problems and run into all sorts of emergencies, outbreaks, you name it. And the CMO is the front person for facing up to all of that and to dealing with it. They're a really essential representative of patient needs and staff concerns at a hospital, and a conduit to upper management and like the politicians that you're talking about. And so to get rid of that very important role is pretty dangerous in my opinion.
Another line from this article, Health New Zealand pledges on Tuesday not to cut. I'll do that again. Health New Zealand pledged on Tuesday not to cut frontline medical roles amid the reset. Would you say a CMO is a frontline medical role?
Yes, I definitely would say CMO is a frontline medical role. Some of them actually are doing clinical work, heading up departments as well. Others aren't. But the point is, when there is a clinical emergency at a hospital, like let's say there's an unexpected death or something gravely wrong, the CMO is like leaps into the fray. Like they're the leadership for the doctors. And of course, there's a chief nursing officer that I believe they're also getting rid of at these hospitals. So you just have to ask yourself, if you're getting rid of the most respected doctor and nurse in a leadership role at a hospital, like what on earth are you doing? It boggles the mind.
It does sound like quite a unique position. Like they're sort of the captain of the doctors, but also they're there to help and represent the patients as well on some level.
Yeah, so I mean, I can't speak for every hospital, but like at our hospital, they're beloved. They've been a clinician and a head of a department and a seminal member of the medical staff for decades. And
Right.
they bring an amazing perspective. When something goes badly wrong at a hospital, you trust that doctor to be there. And what I'm afraid of is if you have a hospital that chooses to, or a system that chooses to get rid of that person and obviously not replace it, what sort of safeguards and safety do you have if you're getting rid of that most respected of clinical leaders?
Yeah. Chewy, do you want to jump in on anything?
This really sounds like just opening up any sort of complicated. This is like me opening up the bonnet of a car and just starting to pull out wires and unplug things to see at what point the engine stops working, at which point I'll walk away and probably pay someone to come and fix it. The thing that leaped out at me there was the mention of Timaru. My dad had a procedure at Timaru Hospital reasonably recently that didn't go well. And I know from experience there that his first point of contact was he was told that, hey, look, our chief medical officer is looking into this to see what is going wrong. Timaru is a place that very heavily voted for national. And I think that they will regret this, because it is very clear that Timaru Hospital will not be a priority, no matter who they voted for. And now, if something goes wrong at Timaru Hospital, they're going to have to rely on what I assume is an overloaded chief medical officer from either Christchurch or Dunedin. If it's Dunedin, he's probably jammed in a janitor's closet breathing in asbestos while he's trying to read out what's going wrong up there. It's just a cascade effect at this point. Would you say that that's accurate?
Yeah, I would say that concern is shared by anyone in a regional hospital. We have in Northland so-called doctorless hospitals that aren't staffed with doctors, that can't find nurses for some of the wards and units, and occasionally or frequently in some cases have to close down either wards or complete emergency intakes. I mean, I'm sure you've been following the Dargaville story for months now, and the Bay of Islands story and the Kaitaia Hospital story. So it's nothing new, but yeah, and so in all of this, there's a big concern that we're seeing the reality of understaffing and underfunding in the public health sector. And yet we're being told repeatedly that we're over budget, that our budget is bloated, that it needs to be cut by a couple $2 billion, that we're overstaffed with nurses, which is the most wild thing. I don't know if you caught an interview with the health commissioner, Lester Levy, being given a simple yes or no question of, are the chief medical officer's frontline staff, and is it true what you say that we are overstaffed by 3,000 nurses? And he couldn't answer either of those questions, honestly. It was a very simple yes or no. Are we overstaffed or are we not? And he found about a half dozen ways to say we're 3,000 nurses over budget, but he could not be pressed to admit that we have grave understaffing issues with nurses. And I think if you can't even be honest about like what is black or what is white, that everything from there on down cascades. And so, yeah, there is concern among clinicians and patients, rural hospitals, city hospitals, that the rhetoric doesn't match up with the reality of what we're facing. And I mean, in that same conversation, I think there was a little subtle switch that I don't know if you caught this, but he went from saying there will be no cuts to frontline services to, quote, there will be no cuts to overall frontline expenditure. And it sounds like the same thing to most normal people. But if you parse that very carefully, it's consistent with other things they've said, which is, the highest funding ever, but they never address inflation. That the funding envelopes and expenditures do not address inflation. And more importantly, they don't address population growth. Yeah. So you've got this amazing, like Alice in Wonderland situation where one person is saying, we're spending more than ever. And the other is saying, you haven't controlled for inflation and you haven't accounted for population growth. And so come on, like you can't, that's disingenuous, isn't it? I mean, it just doesn't make any sense to me, but that's the reality that we're operating in now.
Yeah, and I mean, obviously, when they talk about the highest ever, next year will be the highest ever because there's more. Last year, before this year, was the highest ever. It just naturally increases. But like you say, if it's not per capita or including inflation, you can be the highest ever and still be going backwards. I'm sure.
Yeah, because if nothing else, the population is going to be the highest ever.
Yeah.
Right. It's growing by leaps and bounds. So of course we need to keep up with things like inflation. And of course we need to talk about per capita funding, but that's something that they steer clear of, and you can't pin them down. It's impossible to pin them down on that.
I was going to say to you, Chewy, when you talked about the CMO in Dunedin coming out of the janitor's cupboard filled with asbestos, that's once the new one's been built, eh? Because that's their government's plan for the new building. Because at the moment he doesn't even have a janitor's cupboard. That's right, eh? So after they've done the new one, that's when he'll be upgraded to a janitor's cupboard. That's about it. Yeah, I was just thinking. Yeah, hey, I want to read this to you, Gary, just to nail this down once and for all as well. This is from the RNZ article. RNZ asked Te Whatu Ora Chief Executive Margie Apper and Commissioner Lester Levy if they would confirm there would be no cuts of senior medical people in the near to medium term. Yes, absolutely yes, definitely yes, Levy said. Senior medical roles were a focus, Apper said. How would you respond to that?
They're getting rid of 4 of our country's most experienced, most trusted, and most valued chief medical officers. These are doctors, typically who've had decades of experience. So again, what they say and what is reality don't seem to be matching up. And again, I'm concerned that in an actual live interview, Mr. Levy wouldn't be held down to this idea that there will be no cuts to frontline services. He said there'll be no cuts to overall frontline expenditure. And those are 2 different things. And it leaves open the possibility that frontline services will be cut.
Thank you for joining us. Is there anything else you want to ask, True, before we let Gary go?
Nothing to ask, but just to express sympathy with what you and your colleagues, especially up in Northland, must be dealing with at the moment. I think the medical profession as a whole is just so under pressure to start with, and to be copping this amount of stress, chaos, uncertainty of your future just must be adding to that in an untold manner.
So thank you for that sentiment. Yeah, it is hard to be told your budget is bloated and you're overstaffed and over budget and this and that. But the reality is the doctors and the nurses are not the most important piece in all of this. It's actual patients who are receiving services. And these are who I'm concerned most about are public patients that can't afford private healthcare, right? So again, not Shane Retzi, not Mr. Luxton, not Mr. Levy, but something like half of New Zealand workers make around $30 an hour or less. And these people need the public healthcare system to be strong and effective, to be adequately staffed. They can't have waiting lists that go a year for a second specialist appointment, MRIs that take a year to happen, at the same time that the private sector is getting all of this public taxpayer money and is absolutely booming. So yeah, thank you for the sentiment. It is not an ideal situation for the nurses and doctors, but it's a far worse situation for patients who can't get what they need.
Gary, thank you for joining us tonight. Lots of people in the chat saying things like "Love your work on X." So you've got some people on board here who are thanking you as well. Before you go though, we are going to move into talking about Gumboot Friday, and I know that I saw on Twitter today that you had some thoughts around that. We haven't really explained the story yet, but you got any thoughts you want to put out there about what was announced about Gumboot Friday today? What we're going to look at next?
Yes, I'm sure you'll talk about it, but the idea was basically that there was not appropriate oversight and irresponsibility in giving public taxpayer money to non-governmental agencies at the same time that you are taking money away from public mental health services and public services in general. So
yeah.
There's a big disconnect there. And I think, I mean, for me, it's all kind of related, right? All of these issues really, we're talking about austerity governments. We're talking about what you do when you want to privatize, right? The first step is you defund, and then you destabilize. You watch the public system erode, and people are able to trust it less. And then you say, well, there's only one solution for all this, and it is a private hospital, private teleradiology, corporate telehealth. And down that path lies a bad situation for people who can't afford public health, private insurance, and just for the public in general. The majority of people will struggle when essential public services are privatized. And so I think the Gumboot Friday is part of it. It's all part of it. And every week we're seeing little stories like this that pop up. It's almost too many to counteract. But it's a concerted effort, and I think it's one that will ultimately lead to privatization. And just, if I have 1 second, just remember that they got rid of the Health New Zealand Executive Board, Leadership Board, whatever it was called, and replaced it with one gentleman appointed to the position who essentially has had a hand in every private for-profit business in New Zealand healthcare you can think of, right? He's been involved as an owner, a director, or a founder of literally dozens of private healthcare companies, businesses, corporations. I believe he was the founder of New Zealand's largest private hospital, right, which is Ascot, which I think has now morphed into Mercy Ascot down in Auckland. And you have to ask yourself, why would you get rid of a leadership board in order to install Mr. Private Healthcare? And yeah, some questions really need to be asked if this is the right person and the right situation where you put someone who's a private hospital founder in charge of your public healthcare system. And so there's just a lot of questions about conflicts of interest and motivations. And I think this is a pretty frightening time for anyone in public healthcare in New Zealand.
The other way to think about that as well is, you've said, why would they put someone in that position? Why would someone with his kind of background want that position as well? Like, so it's not just about the government putting him there with what they want him to do. It's him wanting, I mean, he'll be worth megabucks. He won't need this job. He doesn't, it's not like an income for him if he's got private hospitals and stuff behind him. But if he's in that position, he has the availability to then change the rules, which long term might benefit him and his I guess, investor portfolio off as well.
Yeah, the past year has been an amazing time to be in corporate, for-profit, private healthcare. And going forward, the future looks to be even brighter for that group. But that group is not who I have any concerns for. Like, they're not struggling. It's all about people who rely on public hospitals for care and for life-saving care sometimes.
Yeah. And
it's got to keep coming back to that.
And there is that irony with the people who are never going to set foot inside a public hospital are the people who are making all the decisions about how those of us who use public hospitals are going to use public hospitals. So, hey, Gary, thanks so much for joining us tonight. I really appreciate you giving us some time. Emergency doctor out of Northland, it's Dr. Gary Payinda, and we would love to have you back. Got your number now. Love to have you on.
My pleasure,
again.
Pat. Nice meeting you, Chewy, and keep up the important work you do.